Hello and welcome to this lecture on the effect of intrauterine and perinatal events on babies. My name is Joseph Ward and I'm one of the junior doctors working at St Mary's Hospital, and I've done this lecture in conjunction with Rachel Poulton, who's another one of the junior doctors, and Sunit Godambi, who is our consultant neonatologist. So I've simplified these learning objectives here. First we're going to talk about prematurity. Then in the second part of the lecture we're going to talk about surfactant, and finally we're going to talk about birth weight and growth. So first let's talk about some definitions. What is prematurity? Well, any baby born before 37 weeks is preterm, although the due date given to parents is 40 weeks. Babies born before 28 weeks are described as extremely premature. I'm not going to go into much about the outcomes associated with prematurity, but just to give you a bit of an idea, at 23 weeks the babies rarely survive, and those that do have a very high chance of severe disability. By 25 weeks about 2/3 survive and about half have a moderate or severe disability, and after that at 26 and 27 weeks you start getting much better outcomes for these children. So now we're going to discuss some of the common problems associated with prematurity, and we're going to discuss those that affect the brain, the gut, the skin, the risk of infection and immunity. We're going to talk about some of the heart problems that these children get, and also some of the problems associated with the lungs. So firstly, let's talk about neurological problems. And the most common of these is, in preterm babies, is an intraventricular hemorrhage, a bleed into the ventricles of the brain. So why does this happen in premature babies? Well, most bleeds that occur in a region of the brain called the germinal matrix, and this is a highly vascular area of the developing brain that regresses as babies get closer to term. Premature babies, this vascular area is still large enough to have a very high risk of those vessels rupturing and bleeding into the ventricles. The vast majority of bleeds occur within the first few days of life, and it is really uncommon after the first week. As you can imagine, handling the baby or having to transport the baby to a different hospital, or anything that might destabilise them and destabilise this highly vascular area, is going to put them at risk of rupturing and bleeding. To monitor for intraventricular hemorrhages, all babies admitted to the neonatal unit will have a cranial ultrasound scan. Before we look at bleeds into the ventricles though, let's just quickly go over what we're looking at when we take these images. The images in the next few slides are taken from the website of a hospital in New Zealand, and it's in my references at the end of the lecture. This explains it really well if you'd like any further information. So we take pictures in two planes. Firstly, we take 5 pictures in the coronal plane, as shown by these red lines moving from the front to the back, with the images projected as though the baby is looking straight at us. Then we look at the sagittal plane, so moving outwards from the centre, first to the left and then to the right. And we can take these images using an ultrasound probe through the anterior fontanelle of the baby. I don't want to focus too much on the scans, so I will go through these quite quickly, pointing out the main anatomical landmarks we're interested in, from the very front of the baby's head. And the image above is from the second image we take. We can see the frontal horns of both lateral ventricles in this image, and the corpus callosum in the centre. When we're looking at these images, we're looking for asymmetry and areas of brightness around the ventricles. In this image we've moved the probe further back and can still see both lateral ventricles, where we're looking for a bleed just on the underside of one of those lateral ventricles. We'll take 2 further images moving the probe towards the back of the baby's head. Turning the probe 90 degrees, we then take images in the sagittal plane, looking at the baby from the side. And this image is taken from the midline, demonstrating the brainstem and the corpus callosum. And then moving away from the midline to demonstrate the lateral ventricles. And it is in this view that you often see blood in the ventricle or a bleed in the germinal matrix, located in the caudothalamic groove. This area of thinly walled vessels matures after 34 weeks, so that a bleed occurring here are unlikely in more mature babies. We then take a final image, moving the probe right out to the periphery of the brain. It's important to note that an anomaly seen on a cranial ultrasound scan, to call it an anomaly, you have to see it in both planes. So bleeds are categorised according to how severe they are and what complications occur as a result. You can see in the top right image there is an asymmetry just beneath those black holes, the ventricles. Just beneath the hole on the left, the baby's right, you can see an area of brightness, and that's a bleed in the germinal matrix. Equally, when we look sideways on the image on the top left, we can see that area of brightness in the germinal matrix, located, as I mentioned, in the caudothalamic groove. The images on the top are of a grade 1 bleed, and that's a bleed just confined to the germinal matrix. Those on the bottom are of a grade 2 bleed, which is bleeding into the ventricle itself. Here we have a grade 3 bleed on the top, which is bleeding into the ventricle with some associated ventricular dilatation, and you can really appreciate that on the image on the top left. And lastly, at the bottom, we've got a grade 4 bleed, which is a bleed involving the parenchyma. Although grade 1 bleeds often resolve without problems, grade 3 to 4 bleeds are likely to lead to long-term problems, and the baby will be at risk of post-hemorrhagic ventricular dilatation. This is caused by clots forming within the ventricular system, impeding circulation and reabsorption of CSF, and that precedes the development of hydrocephalus. Another common problem to do with prematurity and the neurological system is problems to do with the eyes. Retinopathy of prematurity is a condition that can result in visual impairment and is a consequence of being exposed to very high levels of oxygen in premature babies. Clearly, babies born earlier often need high levels of oxygen due to respiratory problems. The pathophysiology of retinopathy of prematurity is due to the way the retina is vascularized. So vascularization of the retina starts centrally from the optic disc and then progresses peripherally. Being exposed to high levels of oxygen before this process has been completed results in a relative ischemia between the areas of non-vascularized retina in the periphery and those that have been vascularized. This results in the rapid growth of poorly formed, fragile vessels that are prone to bleeding and subsequent damage to the retina, which can then lead to blindness in very severe cases. The risks of developing a retinopathy of prematurity are associated, of course, with prematurity, a low birth weight, chronic lung disease, so needing oxygen for a long period of time, intraventricular hemorrhages, and necrotizing enterocolitis, which we're going to go and talk about a bit later. You can see on this slide, we see a highly vascularized area of retina on the right, and on the left, a poorly vascularized area of retina, with the developing of a ridge of unstable vessels where these two meet, which is what I was talking about relative ischemia between those two areas of the retina. And as it says there, the babies most risk are those born under 32 weeks and with a birth weight of less than 1.5 kilograms. Subsequently, all babies who are premature or have a low birth weight will be screened for retinopathy of prematurity, with the ophthalmologist coming onto the unit to look at the retina of these children. I'm now going to talk about gastrointestinal problems in premature babies, and the really big frightening one for us is that of necrotizing enterocolitis. Necrotizing enterocolitis is a condition of the bowel where the bowel essentially dies, becomes necrotic, may perforate, and this is a life-threatening event. The timing of NEC is inversely proportional to gestational age, so although premature babies get it much more commonly, they get it later than babies who are less premature, who present earlier. There is an increased risk of developing NEC in children, as I said, who are more premature, so with low gestation, with low birth weight, growth restriction, and anything that will cause compromise to perfusion of the gut. This might be twin-to-twin transfusion or a large PDA that can divert blood away from the gut. And I'll talk more about PDAs, patent ductus arteriosus, later. Equally, abruption of the placenta can cause poor perfusion of the gut in utero, and that can then lead to risk of necrotizing enterocolitis after birth. What causes NEC is not fully understood, but there has to be a loss of mucosal integrity, and there is a role for bacteria. The risks of developing NEC are reduced when babies are fed breast milk early and in small amounts, and when the feeds are increased gradually. Clearly, having vigilance for the risk factors for NEC will decrease the likelihood of its occurrence. And we can see here some images. On the left, a horribly distended, tight abdomen, and on the right, air within the bowel wall, as seen on a abdominal X-ray. We're now going to talk a bit about problems to do with skin and prematurity. Babies have a very high surface area to body ratio, and this is compounded by the fact that the skin itself is thin, fragile and poorly keratinized. There's a lack of subcutaneous fat. These two issues contribute to problems with maintaining blood temperature and fluid regulation. So one of the key problems with premature babies is temperature regulation. Another consequence of this premature skin is it also provides a less effective barrier to infection. And I'm going to go on now to talk a little bit about infection and immunity in premature babies. So in addition to the premature skin providing a poor barrier to infection, as I mentioned, and the fact that the premature baby requires multiple invasive procedures which place the baby at risk of infection from an iatrogenic point of view, the immune system as a whole is also less fully developed. A baby's immune system is supplemented by transplacental immunoglobulins, and importantly, only IgG actually crosses the placenta. Passage of this immunoglobulin increases as gestation increases, placing premature babies again at a disadvantage. At 28 weeks, cord IgG levels are about 0.04 grams per litre, but by term they reach 1.8 grams per litre, a 45-fold increase. At the bottom of the screen there you can see the result of an extravasation injury on a baby's arm as a result of a cannula that's tissued. As I mentioned, premature babies, because they need to have so many lines and interventions done, they're at an increased risk of an infection as a result of that. I'm now going to talk about cardiovascular problems with premature babies, and specifically patent ductus arteriosus, which I mentioned briefly when I was talking about risk factors for necrotizing enterocolitis. I'll just start by trying to explain what a PDA is and then why it can become important. A PDA is a remnant of the fetal circulation that connects the aorta to the pulmonary arteries. In utero, this is to divert blood away from the lungs and straight into the systemic circulation. The ductus arteriosus normally closes about 12 to 24 hours after birth in term babies, and 90% will have closed by about 60 hours of age. If it does not, and we will discuss why this might be, this is described as a patent ductus arteriosus. As pressure in the aorta is much higher than the pulmonary arteries, a patent duct will mean that blood flows into the pulmonary vessels, causing a left to right shunt. It is the most common congenital lesion found in the newborn period. So what factors lead to a patent duct, and is it a problem? Well, first let's look at what keeps a duct open in utero. And as I mentioned, this is done to divert blood away from the lungs to the systemic circulation. So the duct is kept open by prostaglandins and prostacyclin produced by the placenta, which have a direct effect of ductal muscle to keep it open. In addition, oxygen tension is low in utero and pulmonary vascular resistance is high, and so it's easier for blood to pass through the duct than to pass through the lungs. At birth, there is no more placenta, obviously, and so there is a reduced circulating prostaglandins. Also, prostaglandin metabolism is increased in the now active lungs, further reducing prostaglandin levels. And finally, oxygen tension is greatly increased, which acts directly on ductal tissue to make it close, and also lowers pulmonary vascular resistance, diverting blood away from the duct. So now it's easier for the blood to pass into the lungs than it is to pass into the systemic circulation. Although PDAs are found in babies born at all gestations, they're very common in premature babies. And why is this? Well, in premature babies, the lungs are immature and damaged, and this leads to poor prostaglandin metabolism. In addition, the duct tissue is more sensitive to the prostaglandin that is around, and also there's a relative hypoxemia, again caused by damaged immature lungs, and that results in lower oxygen tension and so less constriction of the duct, and so higher pulmonary vascular resistance. The murmur of a patent ductus arteriosus is normally heard over the upper left sternum and is described as continuous, If you'd like to hear an example, please go to this website, which has a good selection of normal and abnormal heart sounds. However, it's really important to note that the classical continuous murmur is not always heard in babies, especially not in premature babies, and that's due to the high pulmonary pressure. Sometimes a systolic murmur is heard, or sometimes no murmur at all. So you have to go with other clinical features that might be suggestive of a patent duct. So what are they? Well, include sort of problems with ventilation. So perhaps the baby is having difficulty weaning from ventilatory support. They may have a wide pulse pressure, and that's the gap between the systolic and diastolic blood pressure. They'll have easily felt peripheral pulses due to this dynamic circulation. They may show some respiratory distress and be tachypneic or tachycardic. If it is not treated, a PDA can lead to heart failure and pulmonary hemorrhage. Babies are at risk of necrotizing enterocolitis, as I said. The PDA essentially sort of steals blood that would be going to the gut, and thus sort of reducing perfusion to the gut and increasing the risk of necrotizing enterocolitis. And finally, poor growth is also a common feature of children with clinically significant patent ducted ducts. So if the baby is struggling with the presence of a PDA, one of those clinical features that I mentioned in the last slide, it's sometimes necessary to try and close it. And to do this, we sometimes give prostaglandin antagonists. You remember, prostaglandins are keeping the duct open, so logically if we can try and reduce their effect, we can hopefully close the duct. And this is commonly non-steroidal drugs commonly given. Sometimes, however, the babies will need surgical ligation, perhaps at a later date. Occasionally, however, you might need to do the opposite. You might need to keep the duct open, and that might be if blood flow to the lungs is restricted, for example in congenital cardiac lesions such as pulmonary atresia. In that case, you'll give prostaglandin in the form of an infusion and to keep blood flowing to the lungs while you await surgery. I'm now going to talk a bit about respiratory distress syndrome, and then we're going to talk about the use of surfactant. So, respiratory distress syndrome is the result of surfactant deficiency. As surfactant synthesis increases with increasing gestation, this is more common in preterm babies, but it can occur at any gestation. Babies with RDS present within 4 hours with fast breathing or tachypnea and signs of increased worker breathing with intercostal and subcostal recession, flaring of the nostrils and grunting. These symptoms worsen over the next 24 to 36 hours as small quantities of surfactant disappear due to the inhibitory effect of plasma proteins on surfactant, which leak on to the alveolar. After 36 hours, endogenous surfactant production increases and the respiratory symptoms improve. So RDS is caused by surfactant deficiency. Well, what is surfactant? Surfactant is a complex mixture of lipids and proteins produced in the lung. Its main function is to reduce the surface tension of the alveoli, to increase lung compliance, to stabilise the alveoli and prevent atelectasis, and to prevent fluids traversing the alveoli wall. As I mentioned, surfactant production increases with gestation, so premature babies are more prone to getting RDS. And indeed, below 28 weeks, we prophylactically give all babies surfactant in the expectation they will develop RDS if we don't. However, there are other risk factors. These include diabetes in the mother, birth asphyxia, hypothermia, and placental abruption. Also, babies born by elective C-section are more likely to develop respiratory distress syndrome. Conversely, things that increase production of steroids in utero and thus surfactant will decrease the risk of RDS, and this includes babies who've been stressed in utero due to intrauterine growth restriction or by threatened preterm labour. If the obstetric team is concerned a baby will deliver early, giving the mother steroids also increases surfactant and thus reduces the risk of respiratory distress syndrome. Here we can see a child who's having to work hard to breathe. And you can see that the chest is being indrawn, subcostal recession is quite obvious in that photograph. On the right of the screen we have a classical ground glass appearance on a chest x-ray and air bronchograms, and that's consistent with a picture of surfactant deficiency. So when do we give surfactant and how is it given? Well, as I mentioned, all babies under 28 weeks get surfactant because if we don't, they're very likely to go on to develop RDS because they've not had enough time in utero to produce enough surfactant for themselves. Equally, if babies are requiring a lot of oxygen showing clinical signs of respiratory distress and not improving, perhaps they're on CPAP, they might also be given a dose of surfactant. Cursurf is the brand name for surfactant. It's a fluid and it needs to be given straight into the lungs through an endotracheal tube. In addition to RDS, surfactant is used in both preterm and term babies and multiple other neonatal scenarios to improve respiratory function. And an excellent review of this can be found on the link at the bottom of this slide by the Canadian Paediatric Society, if anyone else is interested. Another respiratory problem associated with prematurity is chronic lung disease. This is defined as oxygen dependency after 28 days of life, or after 36 weeks corrected gestation. Premature lungs are fragile and underdeveloped and can become scarred and inflamed easily, resulting in them being less effective, and the children therefore requiring oxygen to maintain their saturations. This scarring results from ventilating babies with high pressures and high tidal volumes, so we try to use the minimum pressure needed to ventilate effectively, try to extubate them quickly, and the early use of surfactant to increase lung compliance is vital in helping with this. Risk factors for developing chronic lung disease include prematurity, high initial oxygen requirement, as I mentioned, and long periods being on the ventilator with high pressures and tidal volumes. Sepsis in utero, chorioamnionitis, necrotizing enterocolitis and pulmonary hemorrhage are also associated with the development of a chronic oxygen requirement and chronic lung disease. Severe cases of chronic lung disease may become ventilator dependent. However, as the lung continues to grow and develop new air sacs till 2 years of age, there is potential for the lungs to continue to improve their function. Children with chronic lung disease are often wheezy for the first few years of life and are more susceptible to respiratory illnesses such as RSV bronchiolitis, and so are offered immunisations against this with palivizumab. So I'm now going to talk about birth weights and growth. Growth charts are used to plot weights according to gestation. Here we have an example of the UK growth charts which we use on the neonatal units. The boxes here are used to document each recording of weights and head circumference, and these are the main recordings we are interested in. In this area, we document the date at each completed week of gestation until term, and this is for ease of recording the measurements as the baby gets older. The measurements themselves are plotted here with gestation along the x-axis and weight or head circumference on the y-axis. These curved lines on the growth chart show selected percentiles. When a dot is plotted on the 95th percentile line for weight for a particular gestation, it means that only 5% of babies among the population of the same gestation and gender will have a higher weight. These graphs give us an idea as to the size of the baby relative to the general population at each gestation. It can also show clearly if the size of the head is appropriate relative to the weight, and if the baby is growing appropriately according to both their gestation and their starting weight. Crossing centile lines, either upwards or downwards, might suggest a problem with growth, which would then need to be investigated. Now some definitions that are important to learn. Babies with a birth weight under 2.5 kilograms are considered low birth weight. Those under 1.5 kilograms are considered very low birth weight, and those under a kilogram are considered extremely low birth weight. Babies born under the 10th centile for gestation are termed small for gestational age, and those born above the 90th centile are considered large for gestational age. Another important factor to consider is growth velocity, and a slowing of intrauterine growth velocity is termed intrauterine growth restriction. This can be symmetrical, where both the head and weight are small, or asymmetrical, where there is sparing of the head circumference relative to the drop in weight. Symmetrical IUGR commences early in pregnancy and is associated with intrinsic problems such as chromosomal abnormalities or intrauterine infections early on in pregnancy. Asymmetrical IUGR is more associated with placental insufficiency, so this can be secondary to for example, high blood pressure or smoking in pregnancy. Causes of low birth weight can be either to do with maternal factors or fetal factors, and we've touched on some of these already. Maternal factors include extremes of age, so either being very young or very old, a poor socioeconomic status, illnesses in the mother, or drug and alcohol misuse in the mother. Also, clearly, if mum is small, baby is likely to be small, and if there are multiple babies, they're all likely to be smaller than average. Fetal factors associated with low birth weight include chromosomal anomalies, metabolic disorders, infections, and lastly, but probably most commonly, just simply constitutional, so just being a small baby just because that's normal. The image shows a baby born to a mother with preeclampsia next to a mother with a normal pregnancy, so you can see the results of babies of the same gestation but resulting in greatly differing birth weights. Babies who have growth restriction have a higher mortality and are more likely to go on to develop polycythemia, neutropenia and thrombocytopenia. They're also more likely to develop infections and have high risk of necrotizing enterocolitis. Control of their blood sugar is impaired, and this can lead to hypoglycemia, and temperature regulation is also a problem and can lead to hypothermia. So clearly, when we have a small baby on the neonatal unit, we just try and predict that these things are likely to happen. So we might measure their blood sugars and make sure that they're maintaining their blood sugars between feeds. We definitely do all we can to keep them warm, perhaps in an incubator, or explain to mum the importance that they're going to be kept warm. And we're going to be very vigilant as to the risk of infection or also signs of necrotizing enterocolitis or any other problems with the baby that might be secondary to their low birth weight. So